Okay, part two to understanding pain. Let's jump right in. All right, so just to remember again from the first lecture, pain is an unpleasant sensory and emotional experience by definition. Okay, sensory and emotional experience, very important to remember. And what pain isn't is it isn't nociception, and there's a big difference between nociception and pain. Remember, nociception is a stimulus, it's a signal, it's delivered to your brain, it's completely objective. We can measure that signal while your brain is turned off. While pain, on the other hand, is a process, meaning there is not only a signal, that nociceptive signal, but it has to be assigned meaning, and where that assignation is performed is in the brain itself. And pain is completely subjective. Now, also to remind you and remember that pain, the subjective nature of pain, doesn't mean it isn't it's made up or anything. It just means that everybody's pain is different, and it's a subjective experience. Okay, it's also important to remember, which we didn't touch on, that there's a difference between acute pain and chronic pain. Okay, just a very subtle difference here. With acute pain, we believe there's an adaptive role. There's a reason that we have pain. Okay, people have told me in the past, oh, I wish I never experienced pain. No, you don't. There actually is a genetic disease where they lose that nociceptive signal and bad things occur. But pain has a purpose. And particularly with acute pain, what it allows us to do is define the source of the pain. It's generally peripheral, somewhere in your body. Broken leg or a broken bone is this typical kind of thing that we're looking for. And what that tells us is that pain is telling us there's something that is occurring and it may need therapies. And the cut poke drug referred to the three therapies that we have in medicine. Because if you really look at what we have in medical care, traditional medical care, there's only three therapies we can offer people. We either cut you, that's surgery, we poke you with needles, or we drug you with pills. Okay, in an acute pain, generally, will respond to that better because the nociceptive signal, that signal coming from the periphery, is the predominant source. We still have that central component, but if we go after that injury, a little bit better results with it. Now, chronic pain is different. Okay, I believe this is a maladaptive. This isn't very helpful to us overall. The signal can be very nebulous. It is much more central, meaning it is much more brain-based. It is much more how the brain is perceiving this information from the body. If you look at fibromyalgia, that whole body kind of pain syndrome, very hallmark of it is a central pain component, and there is no single treatment. In fact, I can go on rants and raves about this, because if there was a single treatment that worked for this chronic central pain, we would have none, because we try things all the time. Medications, we look at medications and the overabundance of prescription opioids. If we look at the treatments that we've done for back pain, and I'm going to refer to back pain quite a bit in this lecture because that's where most of the literature is. We are spending upwards of, the costs alone with back pain, both direct and indirect, are over $100 billion a year. And our results with back pain are the same or worse than they've been from 20 years ago. Okay, so the pain experience, again, there's acute pain and there's a chronic pain. Now, there is overlap with them because they are both experiences. But if you look at acute pain, probably more of a sensory, more of a nociceptive role involved with that, while chronic pain, much more of this emotional, the central component, the way the brain is processing information. Okay, now in acute pain, if we want to look at duration here, by definition is less than 3 months long. Okay, chronic pain is generally over 3 months. Now this is probably age dependent as well. So if you were young and healthy, acute pain is probably going to be less than 3 months because you recover so much faster. While if you're 80 or 90 and already have bad physical reserves, or you just don't take care of yourself, it's going to take your body significantly longer to heal. So probably be longer than 3 months, but we're going to use that. 3 months, less than 3 months is acute pain, greater than 3 months is chronic pain. There is overlap between them. They both have a sensory and emotional component to it. Acute pain, though, probably more sensory. Go after that sensory role. Chronic pain, probably more of that central base. Okay. Now, all of pain experience is still influenced by, I touched on this, past experience and trauma, the nature of the injury, what your experience has been with pain, what your experience has been with life up to that point in a lot of ways, and then the nature of injury itself. Okay, uncertainty and fear, and we're going to touch on these and how they actually impact pain. And then your beliefs, whether they're adaptive beliefs, constructive beliefs, or maladaptive or destructive beliefs. Okay, the four horsemen of pain. if we look at people who suffer from pain, particularly chronic pain, and there's a lot of people who suffer chronic pain often have more acute pain as well. There are four main horsemen, four main horrible things that happen. One, depression. We're going to talk about that. Anger and how that influences pain. Anxiety and how this one influences pain. And fear. Now, anxiety and fear, there's significant overlap, but 4 horsemen sounds better than the 3 horsemen, so I did use it that way. All right, depression. Now, if you look at chronic pain in general, 40 to 50% of the population that have chronic pain are also depressed. Now, that makes sense because you're suffering for a long amount of time, but it's also a chicken versus egg phenomenon here, because people say, well, it's the pain that brought on the depression, but we also know that depression predisposes chronic pain, okay? So that people that have depression are more likely to develop certain types of chronic pain. In fact, there was a very interesting study that took people who had suffered from major depression with no back pain, and then just used that depression alone, and looked at them 5 years later, and the people that had major depression compared to people who didn't have major depression were 50% more likely to develop chronic back pain. All right. So again, there is an overlay and interplay between depression and chronic pain. Being in pain, can that develop depression? Yes. Having depression, can that develop into pain? Yes. But what this really should kind of make us consider, though, is why is it only 40 to 50% that have chronic pain are depressed? What's the secret to the other ones, and why? And we're going to touch on that towards the end of this little talk. Now, anger. Okay, often don't talk about anger when it comes to chronic pain, but there is a large component with chronic pain of people that have anger. Okay, and that makes sense too. It's widely observed. Right? It is a strong predictor of increased pain, in particular the inhibition of anger. So if you have people that generally express their anger quite a bit, and then they try to stop it, if they actually try to hold in these emotions, they seem to actually hurt more. Now, there's some very, very interesting studies when it comes to anger inhibition, actually some really fascinating ones. One, they took healthy young adults, people without chronic pain, okay? And then what they found is that if they got them in a situation where they were angry and they had inhibited anger, and the study was actually designed that they took these guys and they put them in a room, and one group, while they were in this waiting room, and they were by themselves initially, they said, sit here quietly. And for the second group, they just said, sit here and we'll call you for the next half of the test. Well, what they did after they gave them those instructions, remember the first instruction was sit here quietly, the other one was just sit here, is they put in a second person into the room. And what the experimentee didn't realize is that second person was actually an actor. And the actor's only job in that room was to aggravate and infuriate the person they were in there with. Okay, think of the most annoying person that you can be in there. Now remember, one group was told just to sit here quietly. The other group was just told to sit there. Okay, what they found was the people who were told to sit there quietly, when they took them out of that room, after they'd been inhibiting this anger for such an amount of time, they actually had decreased pain tolerance when they were doing these experimental tests where they were, causing them pain, causing this nociceptive signal that was going to be a painful process for them. And it also increased the intensity of that pain. Okay. Now, they repeated the same study, but this time they used chronic back pain patients. Same typical thing. Put them in the room by themselves initially. One group they said, sit here quietly. The second group they said, just sit here. And they put the actor in with them. And what they found is those people with the chronic back pain not only had increased pain behaviors. Okay, so those people that were told who were inhibiting their anger with this actor started wiggling around more on the streets. They were exhibiting these uncomfortable pain behaviors. But they not only had worse scores, when they went in and they actually did the induced pain part, they had worse pain, they had decreased pain tolerance, but their backs, their chronic back pain hurt. And then fascinatingly, what they did was they measured the muscle activity in the back. They did a test called an EMG, which looks at muscle activity, and the areas where their pain was in the back were actively firing. They had active muscle contraction in their back. This was not like their whole body was tensing up, though, because they looked at the EMG muscle activity in other areas of the body, which was absent. It was only in the areas where their chronic pain was. So what this kind of tells us is there's a feedback loop, that if you have this chronic pain, you can induce a physiologic response by simply changing your emotional state. All right? And particularly if you inhibit that anger, it can worsen it greatly. Now, one of the questions is, who are they angry at? If you have chronic pain, who are you angry at? And a lot of studies were looking at this. A lot of this were tertiary, big pain centers and things. And you hear the typical ones. They're angry at doctors, understandably. They're angry at lawyers if there was some compensation, But most commonly, the person that they were angry at the most was awesome themselves, okay? And if you kind of think about this, it can make sense, because there's a lot of, if there's an injury done and you feel responsible for it, then you become to start beating yourself up over, why did I do this? If I only had not done this action, if I had only not done whatever the case may be, I wouldn't be where I am now. Okay, and so there's this self-anger that is found very common in chronic pain. Okay, anxiety and fear. The enemy is fear. We think it is pain, but it is fear. Now, I think this is really what Gandhi meant when he said the enemy is fear. We think it is hate, but it is fear. Because when we look at chronic pain, and we look at particularly this fear component to it, this really propagates pain. Okay, 40% or greater of people with chronic pain demonstrate anxiety and fear. We do know that anxiety and fear, what primes this pain sensation. If you look at that central component, again, remember that medial pain component, the affective motivational component. We were looking at the 3 dimensions of pain in the last lecture. What anxiety does, it actually primes it. It makes it more receptive to pain. All right, and this, I think we even talked about this a little bit. So if we get somebody who's highly anxious, it makes pain sensation worse, or it's just a nociceptive signal. It gets kind of an increased amplitude, and then the pain experience is worse. We can make things that are normally not painful be painful. There were some very interesting studies where they took patients with, actually these were patients without chronic pain, and they took an extremely cold bar. Okay, one of those when you put something that's so cold and it feels almost hot, and they put it on the back of their necks. Okay, didn't cause any physical damage, but one of the study groups, they told them this is a burning bar, and the other one said just as a cold bar, it's not going to hurt you. All right. When the people felt it but expected it to cause harm, their pain went off the roof. Okay, significantly more, or I should say significantly greater pain experience with this anxiety that there was damage being caused. All right. With people who have chronic anxiety, have worse pain and actually more susceptible to chronic pain in general. It is this volume control on the pain experience. So the more anxious people are, the more likely they're going to have more pain. And we see this in the operating room quite a bit. And a lot of it has to do with uncertainty. Now, I'm going to touch on that volume control a little bit more, because there are certain things that can temporarily improve anxiety. So some of the medications, Valium, Xanax, these are benzodiazepines. They have no, what we would call, inherent analgesic, no inherent pain-relieving quality to them. But commonly, if you give one of these things to treat anxiety to someone who's got chronic pain, they will say that their pain gets better. Now, this is where marijuana comes in. So marijuana doesn't have a large degree of actual inherent analgesic, and when we're talking about actual dampening of a nociceptive signal and or pain-relieving quality to it, but it is a very strong anxiolytic. It relieves anxiety. And when we remove that anxiety, we change the pain experience. Okay, and I think we talked about that a little bit before. Okay, catastrophizing. This is sort of taking that fear and uncertainty and taking it to the worst level. And what we have with catastrophizing is this exaggerated focus towards actual or anticipated pain experience. And these are people who stub their toe and just start going down just digging this pit where not only is it a bruise, now it's a broken bone, or maybe there's a scratch and they're going to get streptococcal infections, and they're going to have flesh-eating bacteria, and they're going to lose their leg. It's sort of taking the worst possible scenario and really living it in your brain, taking this one little initial event and extrapolating the worst possible thing that you can have, and almost living in there now. All right, and this hugely influences pain experience. Behavior and dysfunction. There's all these scales that are involved looking at how people catastrophize, and this predicts dysfunction due to pain, disability due to pain. Now, kinesiophobia, fancy word just meaning fear of movement. And this is when you have excessive fear of movement and re-injury, or re-injury because of your pain. We see this again in back pain quite a bit, where they fear that if they have back pain, it means something's broken and they're gonna be, have something horrible happen to them. And this fear of movement is a huge predictor of not only functional limitations, meaning what people can and can't do, but their performance when they actually are assigned a task to do it. And lastly, disability. So again, back pain, a lot of data on back pain. It's probably, because number one pain complaint. People who are on these self-assessments saying they're scared to move because of their pain, because they know they're going to hurt themselves, that predicts actual disability more than their physical exam does, more than the nature of the injury does. Okay, this is a belief. All right. So the danger here being with this is, it hurts to move, so people don't want to move. Okay, and if people are very terrified of this, they're not going to do what they need to do to improve. So fear and anticipation of pain provides a very strong negative reinforcements for many types of pain. Again, different scenario for you, but the principles are the same. This anticipation of pain, because it leads into this persistent avoidance cycle, meaning, I'm going to use back pain again just because it's so common, but they fear to move because they know it's going to hurt, and so what they do, they don't move, and so they get into it feels okay for briefly, but what they do is they decondition, and as they decondition, then as they move, it hurts more. Because what we didn't talk about is something called proprioception, and all the different little signals in your body that are going on that aren't naturally nociceptive signals. But if you have a brain that is, a chronic pain brain, this brain has been experiencing pain for a certain amount of time, it starts seeing those signals. Remember, we had touched on this with the brain that changes itself. It becomes sensitized. And so different information from your body that is normally not what we would call a nociceptive or noxious or painful pain-generating signal, such as something called proprioception, which is a signal that just tells you where your body is in relation to space, that can be perceived as pain. All right, and again, saw this quite a bit with back pain. Now, what's the effects of these four horsemen then? Well, if you're depressed, you feel helpless and hopeless. You don't really feel engaged. You don't have any desire to try to get better in a lot of situations. Just think, what's the use? The angry generates feelings of frustration and unmotivation. Okay, and then fear or anxiety is fearful of worsening the situation, meaning there's this constant fear of making things even worse than they are. All right, but what about those non-depressed chronic pain patients? What was the secret there? And with non-depressed pain patients, there was a strong belief that they could still function and that they had some control over their pain and lives. And I bolded those words for a reason. Believe they could, and that they had some control. All right. This brings us into the Four Noble Truths here. And those are perception of control, a belief of self-efficacy, optimism and hope, and then benefit finding. All right, so what is perceived control versus learned helplessness? And control is a belief that you can exert influence over your situation. I kind of view perceived control as an external view, meaning you are there, but all the events around you, you believe you have some control over what is happening in your environment. Versus helplessness, which is a belief you have no control over your situation. Okay, that you were there and whatever you do doesn't matter because other people are going to affect you. All right, so perceived control, the belief that you can exert something over your external environment. This decreases disability, okay, while learned helplessness is a strong contributor to disability. Okay, there's also, if people are really interested in this, we can go all over the place with it, but when you look at active versus passive coping strategies, active-passive coping strategies are very much going into this perception of control, or passive coping strategies is this helpless role where you have no belief that everything is external to you and there's nothing that you can do for yourself. Now, self-efficacy is really much more of an internal viewpoint. Belief you can successfully perform a certain task or procedure or desired outcome. This is almost like a mastery belief. A lot of interesting things regarding self-efficacy, but what we do see with it is people that are very self-efficacious, meaning have this internal beliefs of this can-do attitude, have increased function. This also predicts pain tolerance. It predicts pain tolerance. I'm blanking out on something else here. So I'm just going to go ahead. Self-efficacy, very important. Now, optimism and hope. So there is a subtle difference between optimism and hope. And actually, if they look at the studies, they're not one and the same. They do have a little bit of a difference there that we're not going to get into too much, other than when you look at optimism, it's an overall general belief that you're going to experience good versus bad outcomes in life. So generally, everything is good. Okay. Hope is more of a perception of an end goal, meaning that you can plan and pursue progress toward a goal. That is more hope. That is more a focused objective. But with both of them, we see as there's increased health. People adapt better when they have optimism or hope. And then they recover from injury much better with optimism and hope. And this also decreases the pain experience. People who have a lot of optimism or a lot of hope involved decrease the amount of pain. And then lastly, benefit finding here is the ability to identify positive aspects of adverse life circumstances. This is really about meaning finding. When something, that it's a kind of a stupid little analogy, but when life gives you lemons, making lemonades out of it, and that's to find something that is positive out of the situation. Okay, people who can find meaning or find a potential benefit out of what has been handed to them have decreased distress and increased adjustment for their lives. Okay, and this also decreases the pain experience. Now, why do these seem to work, or why do these seem to have an impact on pain? Well, number one, they're more problem focused. So rather than looking at this global, again, this goes into the perceived control kind of phenomenon, but rather as there's all this stuff in life that I can't do about. A lot of these Four Noble Truths are really focusing on a problem. What can you do? Rather than looking at everything that you can't do, what can you do to improve your situation? So problem focused. They're much more flexible and adaptable. Okay, these are also key. Being flexible and adaptable in your approach. If something doesn't work, not wanting to throw up your hands and saying this doesn't work, but saying, okay, this doesn't work. It's important that I understand that so that I don't keep frustrating myself with this. But what else can we do? How can I adapt? How can I move around this? How can I move forward? Whether it's a zigzagging pattern versus just being able to charge straight ahead. Okay, also reframes the context of the injury or reframes the context of the situation. So I was going to touch on acceptance here. I didn't want to overlap these too much, but when you're reframing the context, worst case, best case, something occurred, but it could have been worse. We're trying to reframe it, because very often things can be worse than we think. Okay, even in the worst case scenario, things can still be worse than they are. And recognizing that there is a worst case scenario and that you are not there, provide some benefit. Okay, it means that you can, as things can get worse, that you can get better. And then lastly is acceptance. And I think this one plays a role quite a bit with the anger. There has to be some degree of forgiveness, both to yourself or others. So, I've seen people that were involved with an injury or when there was an external event where, work-related injury or something. The ability to forgive the transaction, it doesn't mean that they were right, or in not taking away blame or anything like that, but it's able to forgive that. It's sort of like releasing that. What am I trying to explain here? It's releasing this anchor that you have to the injury itself. Okay, so work-related injury, you hated your job or hated your boss or whatever, and something happens and you hurt your back. If you focus on that anger there and that hate so much, you're not letting yourself move forward, and you're providing this emotional anchor to that event that is never going to improve. If it's an injury that happened to you, say a single car accident or your own signal injury, and there's this constant blame of why did I do this? A similar thing. There's that emotional anchor that remains tethered to that past event, and it keeps people from moving forward. And acceptance of doesn't mean you have to like it, but accepting what has occurred and saying yes has occurred. There's nothing I can do now. What am I going to do next? Allows you to kind of sever that emotional anchor and move forward. Now, the data is a little bit, we haven't gotten there yet, but my suspicion is that we see as people move into this in this forgiveness role, when they start forgiving themselves or forgiving others and move forward, what I think we're going to see is we're going to see some changes in the brain as well, and we're going to see some changes on how people have that pain perception, that pain experience, because they're never not going to be dwelling on this anymore. Okay, not the greatest explanation. I'm sorry, I'm sorry about that, but it's an evolving concept, I guess I would say. Now, overall, what does this all mean? Well, again, pain is not nociception. The reason I keep hammering this is because if you look at the news and you look at what people are talking about, and you're looking oftentimes what doctors are talking about, we're not talking about pain. We're talking about nociception. We're talking about a signal. Okay? And that chronic pain is not acute pain. So acute pain, I have the slide there. Again, acute pain is still a pain experience. There is a central component. So we're looking over at that chronic emotional side with the overlap there. But there's a sensory role, and if you have a broken bone, if you stabilize that bone, if we put it in a cast, and their ends are not grinding on each other anymore, generally that pain shall improve. Should. Again, there's all those other little things going on involved with there, but if we direct our therapies toward that sensory model, probably will improve a little bit better. Versus chronic pain, if we continue to try to focus on just the nociceptive signal, we're not dealing with the mainstay, meaning a brain that has been in its pain experience for a long duration of time is going to be different. Okay, I saw this quite a bit when we used to go after someone who had chronic pain for a long period of time. What you do is you do an injection in their back or whatever. Maybe their back pain got better, but they still have continued input. I mean, there's always signals coming from your body that are going to your brain. Whether it's a nociceptive signal like a hurt joint, or even what I said, a proprioceptive signal, meaning there's information just telling where that limb is in relation to space. That information is coming to the brain. And if the brain doesn't change, it can take those signals and process them as pain. So you inject somebody who's got chronic pain in their back pain may seem to improve, but what happens? If they have shoulder pain, the shoulder pain may get worse. They may start experiencing headaches. They stub their toe, and their toe may get worse because of that central component, that pain brain, is still heightened, is still sensitized. Those external stimulus will be amplified. Okay, so what do we do? Well, if they have a broken bone, obviously you go after the bone, but we still need to focus on that central side. And very little of the therapies that we're doing in medicine now are working there. Now, medications, we can talk about medications a little bit, but medications for chronic pain are basically just working on neurotransmitters. They're not working on the base of the problem. They're just trying to dampen it. And so if you look at chronic pain medications, most of which come from anti-seizure medications, all they do is dampen everything because they're not specific to any pain pathway. Again, you probably don't want them to be. That's another lecture there. But so they may improve chronic pain 30%, 10%, 20%, certainly no greater than 50%. And over time that gets worse because if you take away 30% of someone's pain, 2 months, 3 months, 4 months down the road, people's brains are very resilient, and that 70% of pain becomes the new 100% of pain. I call it the pie of pain analogy, where if you have like a blueberry pie and you cut out a sliver of the pie, maybe 20% of the pie, first it looks like there's a big chunk out of the pie, but over time that filling seeps in and covers up that hole again. And so focusing on these external nociceptive signals or trying to cover it with drugs isn't going to work. We need to start working on that chronic central side and changing the way that we process the pain experience. Okay, and that really comes down to perception, beliefs, and we talked about maladaptive and adaptive beliefs, and well as meaning finding. All right. So comments, questions, or confused? I hope this wasn't super confusing. I was going really, really fast. I felt I was taking way too long doing this, and it was just getting too long. There is a part 3 on this. We can start moving into a little bit more actionable how-to stuff, but I think these first 2 lectures are really important because they provide the why and the what. Okay, and we always want to do the hows, but the why and the what are really important, particularly when it comes to pain, because if you can understand, the information that we're putting out about pain, what pain really is, that it's an experience, it's not necessarily a thing. At least it gives people a way to think about it differently, and kind of start focusing on more of an end game that works. And the other thing I think it does, or at least I mean, you can tell me whether it does this or not, is it allows you again to have more control over the situation. That you can perceive that there are things that you can do for pain. You may not be able to understand what you can do completely, but if you recognize how the pain is processed in here, you can start saying, well, how am I going to interrupt this? How am I going to take control of these situations? Which is very different than what we do typically in medicine. Okay, so sorry this has taken so long. I can't believe how fast time is going by. It's kind of a little bit scary for me. But again, if you have any questions or whatever, let me know. And hopefully maybe we'll touch base. I'm going to email you right after I do this, okay? All right, thanks.